GE Healthcare would like to welcome you to the session Digital Technology – Impact on Cardiac Imaging. In today's session, we'll be joined by academic visionaries who will discuss how digital technology is impacting cardiac imaging. This session will focus on 3 product areas, including easy patient management with new cardiac CZT solutions, experiences with Discovery MI within a state-of-the-art cardiac PET imaging lab, and implementing production of 13N ammonia in an in-house PET radiopharmacy. Our first speaker, Professor Tali Sharir, join us from Assuta Medical Center in Tel Aviv, Israel, where Professor Sharir leads the nuclear cardiology department.
Thank you for inviting me to share my experience with the MyoSpect camera, and I'll do it showing a few clinical cases. So this is our standard protocol with a CZT camera in patients non-obese. We start with a stress. It's a stress first protocol with injection of a half dose, 5 millicurie at peak stress, either a treadmill exercise or vasodilator dipyridamole stress. This is followed by a supine stress acquisition over 5 minutes, then a stress prone acquisition. Then we inject the resting dose of 50 millicurie, which is followed 1 hour later by a resting supine acquisition over 3 minutes. In patients with high BMI, more than 35, we use the extended field of view option. And this is done using higher injected doses, as shown here, and a longer acquisition time compared to the standard protocol. So the first case is a male, 69 years old, weighing 150 kilograms with BMI 42.9. His risk factors: hypertension, high cholesterol. He underwent a coronary bypass surgery a few years ago and referred to myocardial perfusion imaging due to atypical angina and shortness of breath on effort. The patient was recruited to our study comparing imaging with MyoSpect using the extended field of view option and the standard conventional camera, the Discovery 670 camera. As you can see, the images of the MyoSpect with the extended field of view are characterized by better resolution compared to the conventional camera, with thinner ventricular wall, larger cavity, and better resolution. Actually, both images demonstrate the same finding of a non-reversible perfusion defect in the inferior, infraapical, and infroseptal walls, which is consistent of moderate-sized myocardial infarction in the right coronary artery territory. So from this case, we learn that the MyoSpect provided images with better resolution, higher quality with the CZT technology compared to the conventional technology. So the second case is a female, 54 years old, weighing 116 kilograms with BMI 41.6. She suffers from end-stage renal failure and referred as part of evaluation before renal transplantation. She had dipyridamole stress and injected with technetium sestamibi only 9 millicurie, a low dose, and imaged on the myospect camera with the extended field of view reconstruction. So the images, as you can see, these are the stress images, are of excellent quality, high resolution, and showing normal myocardial perfusion at stress. So the study was terminated, sparing the resting injection, and the patient ended up with a stress-only test. So to conclude this case, it's a normal myocardial perfusion imaging using low-dose stress-only protocol in an obese patient, a female patient with BMI 41.6. Before we had the myospect camera, we could not image this patient on a CZT camera and obtain such good images. So the third case is a female, 55 years old, weighing 132 kilograms, with a BMI of 50.3. She suffers from hypertension, high cholesterol. She's an active smoker with 35 PEC years. She had bariatric surgery a few years ago and referred for nuclear testing because of atypical angina and shortness of breath on effort. So this patient, the same as the first case, was recruited for our study comparing the myospect imaging to a conventional camera imaging. So if we start looking at the conventional camera imaging, we see images of poor quality, non-uniform. We see a defect in the anteroseptal and anterior wall, which has the characteristics of a motion artifact in the short axis slices as well as the horizontal long axis slices. So we suspect of severe motion during this acquisition. In contrast, the myospect images with the extended field of view option are characterized by high resolution, very good images with a small reversible perfusion deficit in the inferoapical region, suspected of small amount of ischemia in the distal LAD territory. So if we examine again the images of the conventional camera, the Discovery 670, and we look at the raw images, the rotating images, we see indeed there was a severe motion, mainly horizontal, but to some extent vertical as well, during acquisition. And this kind of complex motion is hard to correct using motion correction artifacts. So actually, this study by the conventional camera is non-diagnostic. Using the conventional camera with the CT, we performed a scan for coronary calcium. And as shown here, the coronary calcium score was high, 405, and with high percentile by age of 95. The distribution of coronary calcification was in the 3 coronary territories. So if we look again at the myospect images, we can see the infraoapical ischemia, but also we see that a transient ischemic dilation of the left ventricle in the stress compared to the rest images. If we look at the gated images, we see normal contraction at rest and small apical akinesis at the post-stress acquisition. So if we summarize this case, based on the myospect images, we can say this patient has mild infraapical ischemia consistent with distal LAD stenosis. She also had transient ischemic dilatation, suggesting that the coronary disease might be more extensive than shown in the perfusion images. We see post-stress apical akinesis and severe coronary calcification. All this diagnosis was possible due to the myospect acquisition. Thank you for your attention.
Thank you, Professor Sharir, for sharing your first impressions of myospect and walking us through the world's first patient images from the product. Now we're going to Turku, Finland, where Professor Juhani Knuuti will take us through modern diagnosis in cardiac diseases with PET-CT.
Ladies and gentlemen, I would like to first thank the organizers for inviting me to talk about this topic about modern diagnosis in cardiac disease with PET-CT. Here are my disclosures. As we know, the current clinical indications for PET in cardiology are those three which are written here. First, the detection of coronary disease, likely the major indication. Then actually the first indication was the assessment of myocardial viability in heart failure, and the most emerging application are those with the inflammatory and infectious cardiac diseases. In this presentation, I will focus on the detection of coronary disease. Now I would like to start this discussion by sharing you the most recent ESC guideline about how the patient with chest pain will have the diagnostic testing for a coronary disease. As in the previous edition of the guideline, this guideline also uses the pretest probability of the coronary disease as a basis. Here we talk about the clinical likelihood of coronary disease, which is a little bit more extended than the basic pretest probability, because it includes also the clinical indications and risk factors. The main message is still the same, that after evaluation the pretest probability or clinical likelihood of the disease, then the testing is recommended to being a non-invasive when the likelihood is intermediate. But in the way that if the likelihood is very low, then the anatomical test like CT angiography is a good option, while the patients with a higher likelihood, testing for ischemia is a preferred option. But please remember that any of those tests are still valid to be used in any of these patients with intermediate pretest clinical likelihood. And it is stated in the guideline that the choice of the test is based on the clinical likelihood, patient characteristics, and preference availability, as well as local expertise. So it is not only the test quality which is determining, but also the expertise and availability of each of the testing. So non-invasive testing has still a major role here, but it is flexible in a way. One of the issues which we should also keep in mind when we are thinking about the role of different imaging testing in cardiac disease is that traditionally we have been thinking about diagnosis of the disease. Recently we have also focused about prognosis, how much this diagnostic test will give information about the prognosis, which is a major determinant of what we are doing with the patients, having a low or high risk of the disease caused by the disease. meaning risk of event, not the risk of the disease itself. And ultimately, of course, the idea would be that our diagnostics and prognosis information will have important impact in guiding the therapy decision and hopefully guiding in the way that we will improve the patient outcomes. So it's not only the detection of the disease, but information, the prognosis, and the power of the test to guide the therapy decision. And that's making really a clinical impact to our patient care. If we now focus on PET in general, and this data is actually not based on the most recent PET studies where absolute quantification has been applied, but generally any PET data information in the literature, we can see from this graph that PET is really a strong and accurate test to either rule out or rule in coronary disease. Let me explain a little bit about this graph because it's a busy graph. So if you look the left panel, the reference standard there is anatomical obstructive disease based on the invasive angiography and visual assessment. And there, if you look, the green color means when the test can rule out the coronary disease, and the red color denotes the area of clinical likelihood when the test can rule in the coronary disease. So the longer is the green and red bars, and more they overlap, the test is better. And if you look the PET part of it, you will see that the PET behaves and is the best test out of those compared. And this is even emphasized more if you look the right side of the panel, where the reference standard is not only anatomical disease but also functionally detected obstructive disease by means of FFR. As you see, the green bars and the red bars are very wide and overlapping also significantly, meaning that PET is very good test to rule in or rule out the coronary disease when the reference standard is functional testing. And as you see above, for example, CT angiography, invasive angiography, then when the functional reference standard is used, the anatomical information is not that good anymore to ruling in coronary disease. It works pretty well in ruling out. So what is the reason why PET is so good? Can be explained by many factors, but one of the factors is the absolute quantification. So with PET you can quantify myocardial perfusion in absolute terms, and if you think about which patients it will really give a benefit, of course it's obvious that those with the balanced 3-vessel or severe multi-vessel disease, then the absolute quantification is likely increasing the sensitivity of detecting the severity of the disease. It also helps in the culprit lesion versus non-culprit lesion comparison, especially in those with the multi-vessel disease. It also allows to look about the early changes in coronary dysfunction, because you don't need to have relative differences in your myocardial regions. So even this true benefit of PET has not been utilized in many of the previous trials. The previous slide showed a very good performance of PET, but it can be even further improved by applying quantification. Now, how to do the quantification? This is not beyond the talk of today, but there have been a lot of publications, a lot of protocols how to dynamic studies with PET with the different tracers are applied, and then there are a number of different software packages which enables you to quantify myocardial perfusion in absolute terms. Currently, the only CE-marked software for radio water PET perfusion is the Karimas software, which we have been developed. But also many others with different tracers are available. Somebody may thought that this is a complicated thing to perform a dynamic studies in a routine basis, but actually it is not. There are simply dynamic studies performed with the current scanners, which are very short in time, very rapid, and the post-processing of images as well as the full quantification won't take actually not much time and resources, and are very easily applicable in a clinical routine. One of the questions, of course, is that when you do the quantification, how do you interpret the findings? Luckily, we have now increasing amount of information about how to read the absolute values from the flow. This is our joint work with Amsterdam and Uppsala, where we demonstrated, based on the radio water stress perfusion, what is the optimal cutoff value for the normal or abnormal myocardial perfusion, and we found out that with the stress myocardial blood flow in absolute terms, 2.3 mils per gram per minute was the optimal cutoff, or the flow reserve 2.5, and we got very high sensitivity, specificity, negative and positive predictive values using those cutoffs. And here we had an FFR as a reference standard, not only the anatomical lesion lumen narrowing. We have also shown in some smaller studies how much the absolute quantification will improve the accuracy, and here we are focusing only the multivessel disease, patients with a multivessel disease, and as you see, the blue bars using relative image reading versus the green bars showing using the absolute perfusion is definitely improving both the positive and negative predictive value, and naturally, of course, accuracy. But you need to remember that this drastic benefit is now visible here in this study in the patients with the multivessel disease, where the challenges with the relative analysis are, of course, more clear. Many people are always worried about the balanced three vessel disease. That's a fact that these patients happen, but they were not very common in this population. Only 2% of the patients had really a truly balanced three vessel disease. But it was seen that in many other patients, the disease severity is usually underestimated with the relative image analysis. We also showed that when you use absolute quantification, you don't need to use rest and stress imaging, because in most of those patients only stress imaging is needed. Only in patients with a known disease or previous myocardial infarction or LV dysfunction, then of course rest and stress need to be performed. But in most of the patients without any previous cardiac events, stress-only approach is actually as accurate than the rest and stress perfusion imaging. And that's because we use only the hyperemic myocardial blood flow as a criteria for normalcy, and we know now the cutoff values, what is normal and what is abnormal. The same finding has been found in thereafter in several multi-center trials. There are two examples I will show here. The first one is this EANM study, which had nearly 500 patients, and there the PET perfusion was best out of the functional tests in sensitivity and specificity. In this study, CTCA was the best one of all these techniques, but this is easily explainable in a way that we didn't have the FFR as a reference standard, but rather invasive angiography. So anatomy is more correlating with anatomy, and the functional information is usually correlating better with the functional reference standard, and that will explain it. Then about the scanners. So we have been using radio water as a routine test for cardiac perfusion from 90s, and clinical service we started 2005. And there are a large number of patients which have been passing through this clinical service. Now we got a new fully digital PET scanner, and then we of course were interested how much this new scanner will have an impact on the accuracy of diagnosis, but also especially on the absolute perfusion measurement. And that's why our team performed this kind of study, where we performed a phantom studies to compare the previous generation of PET scanners with those non-fully digital versions versus the most recent fully digital PET scanners. And what we learned, and not surprisingly of course, that when we use different activity levels, we found that there's a much higher count rate in the fully digital PET scanner versus the analog one. And here we compare the DMI and D690 scanners. Here in the left upper panel you will see the red dots versus the blue dots. It's much more counts with a certain level of radioactivity. Then we compared how the curves behave in different scanner types. When we injected different amounts of the tracers, you see very nicely in both scanners you will get a very smooth and nice time activity curves from input and output curves. And even more importantly, we were keen on what would happen in the quantification. And as you see here, when you increase the activity, injected activity, your area under curve is very strongly linear, and there was practically no difference in any of those scanners in the accuracy of quantification. And that's of course very good information, because if you want to use a PET as a tool to measure absolute quantification, then of course the performance in this sense is a critical parameter. What you can see easily is the image quality, because those who use radio water, they know that the water is very rapidly diffusing from the blood to the tissues, and then you need to create a kind of parametric image, or you need to create so-called difference image, a subtraction image, which is then used for the segmentation. And the big difference is now that as compared to old generation of the PET scanners versus the most recent PET scanners, then the image quality for the segmentation has been significantly improved. So that makes the analysis of the water PET images very rapid and very robust, because the image quality is so much improved. And that's, I believe, will also improve our accuracy. So summarizing the comparison between the analog and digital systems, I could summarize that the quantification of flow is accurate in the digital version, and it's preserved over various injected activities, and similar in both scanners. So that's an encouraging finding. And also the errors were comparable in flow quantification in both systems. And we learned that and with the new digital versions, the quantification accuracy is preserved over activities from 300 to up to 1200 megapixels, which is very much higher what we are routinely using today, because when we got this higher sensitivity scanner, we dropped our radio water injection from 1100 to 500 megapixels. And also we believe that the better count rate performance of the digital version, as you see, only 12% error in almost 13 megacps, versus in a D690 there was 7% error at the level of 6.8 megacps. So it is likely that this better count rate performance combined with the tolerance of the scanner for a rather high radiation tracer dose will allow to even further improve the accuracy of the quantification, because we could now even maybe double the radio water dose without saturating the scanner, and likely the image quality will further improve. And with the radio water, the radiation dose for the patient is not a major issue because the clinical dose is only 0.4 millisieverts. But we need to do some further studies to assess the system performance at the higher injected activities, because it could be that we could go even higher. But currently, because we don't know, we recommend performing microperfusion imaging under that 1200 megapixels activity when the Discovery MI20 is used. I would like to finally summarize my presentation about the modern diagnosis in cardiac disease with CT, focused specifically on the coronary disease. PET has been demonstrated one of the best imaging methods for detection of coronary disease, and it has been clearly shown that the quantification has a major impact on the accuracy and detection of coronary disease, and especially on its severity. The digital scanners' performance on quantification should be confirmed, because the generations are now changing from analog to digital. And when we look the flow quantification accuracy using Discovery MI PET-CT, we found it's very well preserved over activities at least from 300 to 1200 megapixels of radio water. We look in the future to whether we can improve further from our current level by increasing the radioactivity levels, the tracer dose levels, but also we need to study a little bit more about how the better count rate performance could really give a further improvement. But even now it looks that it's a step ahead from the previous scanners, also in the field of cardiac perfusion imaging. Thank you very much for your attention.
Thank you for sharing your experience with us, Professor Knuuti. To recap, you shared 3 important takeaways with us. First, you shared that PET is one of the best imaging methods for detection of coronary artery disease. Second, quantitation has a major impact on detection accuracy and severity assessment. And third, the better count rates of digital systems suggest benefits over analog systems. Finally, we'll head to Bergen, Norway, where Dr. Adamsen will discuss implementing production of 13N ammonia in an in-house PET radiopharmacy.
So, welcome to this short presentation on how we plan to implement N13 ammonia in our in-house radiopharmacy. I am Tom Christian Holm Adamsen. I'm the chief radiochemist and the head of production at the Center of Nuclear Medicine at Haukeland University Hospital. During this talk, I will present the current status and possibilities for maximizing the production and scanner capability at our hospital. So, a little disclaimer. So, a little bit on the background. Situated in Bergen, Western Norway, Haukeland University Hospital is the second largest hospital in Norway, with about 13,000 employees and roughly 1 million patient consultations per year. At the Nuclear Medicine Department, we do approximately 5,000 procedures per year, and this comprises all modalities and includes diagnostics and therapy. So the Center for Nuclear Medicine is a section under the Department of Radiology and comprises of approximately 50 employees with backgrounds as nuclear medicine physicians, radiographers, nurses, chemists, physicists, and pharmacists. And it's been operational in its current form since 2009. So we are a complete and modern center for nuclear medicine with all the modalities and current therapies available. Our imaging equipment was completely renewed in 2018, and in 2019 a PET-MR was added to the portfolio. The Radiopharmacy has been producing PET radiopharmaceuticals since 2011, and it's expanding its tracer portfolio under national regulations every year. Research and development in radiochemistry is conducted together with the Department of Chemistry at the University of Bergen and other partner institutions. So the Radiopharmacy labs, or the Radiopharmacy, is currently at one lab, which is a clean room grade C, which all the radiopharmaceutical productions are taking place under GMP and national approval. So in the current setup, we produce with a Petrace 280 or Petrace 860 cyclotron. We have 2 fast lab developers. We have a Mosaic system and an Eckert and Ziegler farm tracer. All of these are a part of the tracer portfolio that we currently have in our site. So the production capacity is limited by the number of qualified hot cells. So we have 4 hot cells, and the synthesis modules installed. Of course, FTG has a priority over other tracers purely due to demand. So we are a purely in-house production radiopharmacy, although we have marketing authorizations for FTG. And we are also the sole producer of some tracers in Norway, but the geography of Norway demands air freight for most of these tracers, and that will add to the cost significantly. So it's easier to bring the patient to us than the tracers to others. So the current tracer portfolio is, of course, FTG, which we have with marketing authorization. If needed, we could then sell it. We produce PSMA 1007, FLT, F-MISO, F-DOPA, carbon-11 methionine, and also gallium-68 DOTATOC. So of these tracers, FTG is about 80% of the total load. And that, of course, leaves little or no room for adding tracers to the portfolio, while at the same time keeping up with the demand of the current tracers from the clinicians. And of course, if we would have a failed synthesis, FTG synthesis, that would have a impact on, for example, F-MISO or F-DOPA productions. So a typical week, looking at the load on the radiopharmacy and the scanners, we can see that every day we spend or use more of the synthesis modules to capacity. So there's a little room for error, and thankfully the systems are robust enough that they very seldom have any errors. But of course, from time to time, that will happen. So this schedule here is busy not only for the radiopharmacy but also for the scanners. So what do we do then if we get a demand for a new scanner or a new tracer? That actually happened not long ago when the cardiologists requested a tracer for perfusion imaging. So how can we, as a small radiopharmacy almost working at capacity, implement a tracer? So we looked into the literature and discussed with the clinicians the different options that we had. So O15 water, which is a excellent tracer, we did not have the required infrastructure or hardware available at the PET-MR scanner, which is the desired modality to use for these cardiac examinations. There's another tracer, F18 fluoropyridase, which could be produced at the FastLab 2, which is already at capacity, but that tracer is not yet available. And another option is then N13 ammonia. For ammonia, we have to find clever ways to produce multiple doses because of also the short half-life, but also because the radiopharmacy as a whole is at capacity, as said before. So how do we do that? And which of these tracers should we then aim to produce? So after discussions, we came to the conclusion that ammonia was the most probable candidate, but there were some potential pitfalls, and that was the short half-life of nitrogen 13, making quality control of each batch a challenge. We would consider on which production platform we would use, or even procure an additional system. A flexible system that allows for multiple runs maybe, or a single cassette or disposable had to be considered. And also the ability to schedule the production in between tracers on irregular intervals was also of importance. So based on those requirements or needs, we got into a discussion with GE Healthcare regarding a new system, which is the EANM ammonia purification system, which is a flexible purification module that can do 9 runs or 8 runs for patients for purifying in-target produced ammonia. So one of these runs, let's say one of the 9 runs is used for quality control, and the remaining runs then for patient examinations. So depending on number of scanners and which modality is desired, we can either go from 8 maybe to up to 16 patients in total, or at least 16 examinations in total if you include stress and no stress. And another thing is that the system is easy to prepare, and it has an easy purification, which can be scheduled within the 48-hour system or 48-hour period. So we would use the first batch or the first run to do quality control, which is in the requirements of the European Pharmacopoeia, and that would include pH, radiochemical purity, appearance, half-life, endotoxins, and sterility. And the subsequent runs would then only be required to do a simple pH measurement before administration to the patients. And that would save a lot of time, of course, for the quality control. You're sort of limited within the 10-minute half-life to do a lot of quality control. So if you then spend the first batch for quality control, then the subsequent ones are easy to administer to the patients. So with that said, how do we envision the ammonia in our busy schedule? So since the EANM system has a 48-hour usage time for the cassette or the multiple run cassettes, we could then put in ammonia in multiple days and fit into the already existing schedule. So we can do patients in between different tracers and during production of other tracers as well. So this is a fairly realistic setup for our site. So and before we can actually take that into clinical use, we have to go through some implementation steps, and one of these are evaluation of system and suitability tests when the IRENE system is in its final form. We're now doing a evaluation together with GE on the system, and then we have to do the performance and process validation of the system, which then will be a dossier which we'll hand into the Norwegian Medicinal Agency for approval and get a license for in-house production. And with those steps being taken, we hopefully will have ammonia in clinical use by the second quarter of 2022. And with that said, then I thank you for your attention, and good luck with ammonia or any other cardiac tracer.
Thank you for that insightful presentation, Dr. Adamsen. The key points we should all remember are: implementing cardiac PET imaging is often up to the Radiopharmarcy ability to implement new production batches. 13N ammonia is a tracer of choice, although it is labour-intensive. Utilisation of a multi-run purification module helps production workflow along with imaging schedule. And, as with every new PET tracer, a comprehensive implementation is required and takes several months before starting clinical use. Thank you to our speakers and audience today. We appreciate you taking the time to listen to the ways digital technology is changing cardiac imaging to help deliver better outcomes. We invite you to learn more about digital technology and how the future of molecular imaging is personal at the GE Experience at EANM’21 Virtual.